I'm honored to moderate this session. We have now today two distinguished speakers, and they will debate on are twins an adverse IVF outcome. We will hear for and against to twin or not to twin. And it will be held by Professor Gleicher, who is the medical director and chief scientist, the Center of Human Reproduction here in New York, the president of the Foundation of Reproductive Medicine, professor Stem Cell and Molecular Embryology Laboratory at the Rockefeller University, and editor-in-chief emeritus of Journal Assisted Reproductive Genetics at the American Journal of Reproductive Medicine. Please, Norbert.
Thank you. It is a pleasure to follow Eliadashi, and I have to say that I have to return his compliments because there are very few people in our profession, if any, who I value as much in their intellect and in their detailed knowledge of topics that they address. And in having had the prerogative to put the program for this meeting together, that was exactly the motivation why I asked Eli to join me in this debate. And the reason is, in principle, that I knew that he did not represent the extremist opinion of let's only do elective single embryo transfer. That would be an easy debate for me to hold, because as he also represented, that is probably a completely insensible opinion to hold. As he outlined in those 5 points, there is simply no support to say that every woman, independent of age, independent of ovarian reserve, etc., independent of her will, should have to undergo elective single embryo transfer. Yet, there are big parts of this world and of the developed world where exactly that is already happening. There are countries where it is legislated that IVF has to be performed by elective embryo transfer. So my selection of Eli to present the opinion that there are too many twins already being born comes with that background. It is much more difficult to debate somebody who is not only smart but is also nuanced in his opinion. And what you just heard was a very nuanced opinion. So this is just the advantage of being the second speaker, because I can respond to the first one. And now let me go to my prepared talk. Conflict statements, there's really no conflict with this topic. What I want to present to you in my argument is actually also pretty much what you just have heard from Eli. But a little bit to the right, a little bit to the left of him, whichever way you want to politically look at it. Because our opinion at our center, and Eli is correct, as far as I know, we are the only group who has been very public in our stance against this general drive towards universal elective single embryo transfer that started in Europe but has now also crossed the Atlantic and has some very strong and radical proponents in this country. We have been for a long time speaking out to it, but not by arguing there should never be an elective embryo transfer, a single embryo transfer. Our position is just as nuanced. We feel that there may be obvious cases where an elective single embryo transfer is the best choice. And then an elective single embryo transfer should be performed. But we also feel that there are many cases, probably a large majority, where for objective reasons, an elective single embryo transfer, in our opinion, is not the best choice. And we are making this argument, we think, based on solid statistical data. And I want to go with you quickly through those data. The whole concept of elective single embryo transfer is based on certain assumptions. We wouldn't be here and talk about elective single embryo transfer if there was not a conviction out there that twin pregnancies carry increased risk in comparison to singleton embryo transfer. Because if that wasn't the basic assumption, why not have twins? So the whole elective single embryo transfer is really based on the fact that it is believed that twins are more dangerous to offspring as well as mothers as singletons. There's also a strong belief out there that it is IVF that it is causing the twin epidemic that Ellie showed you. And yes, we have a twin epidemic in the United States and actually in other countries as well. I'm sure you have not heard about other causes for this epidemic. You hear it only in conjunction with IVF. This is also based now, especially in recent years, on the idea that by selecting out so-called normal embryos and transferring one normal, chromosomally proven normal embryo, we can get better pregnancy chances than we used to get before we could select embryos. Now, I will spend the rest of my time demonstrating to you that all these three assumptions underlying the general concept and the general drive towards elective single embryo transfer are really mistaken. We indeed have come to the conclusion that elective single embryo transfer for a majority of women is a harmful procedure, because when we do something in medicine, we establish a risk-benefit ratio. And Ellie acknowledged beyond any reasonable doubt that if we take 100 women and split them in half and do in 50 single embryo transfer and the other 50 two embryo transfer, there's no question that the two embryo transfer patient group will have higher pregnancy and live birth rates. So there's no discussion about the fact that transferring two embryos will give you better IVF outcomes. Now, that by itself doesn't mean that we should do all two embryo transfers. It means that unless there is, on the other side of the equation, a benefit that compensates for the benefit of better pregnancy chances and live birth rates, without such a benefit, there's no reason to do the less productive procedure. And Ellie referred to the point that, and he agreed with the point, which was the main argument against elective single embryo transfer that we have had for really 10 years, almost 10 years. And that main argument is that if I ask the average obstetrician gynecologist, and probably you, the simple question, do twins have higher outcome risks than singletons? I would say probably 99% of you will say yes. Even I would say yes. Because that is a logical answer. This is what we learned when we became general obstetrician gynecologists. But that knowledge comes from a retrospective obstetrical paradigm, where obstetricians delivered babies in the old days without ultrasound, and thereby frequently were surprised when twins were delivered. And they recorded in the medical literature that twin pregnancies had much higher risks, both on the maternal and on the fetal side, than singletons. Logical. But this is not the statistical circumstance that we face in reproductive endocrinology. We don't face a retrospective established paradigm where we compare outcomes. We really face a prospective paradigm where an infertile woman comes to you and says, "Doctor, help me build my family." And you will ask her, "Okay, what are your plans? How many children?" And she says, "At least 2. So our problem now is to help this woman to have prospectively 2 children. And the question that we therefore have to ask, what is the best way, the safest, the most cost-effective, overall the best way to give this patient prospectively the best chance to have 2 healthy children? And the answer to that is obviously not using the data from the retroactive obstetrical paradigm, which compares the birth of 2 children to the birth of 1 child, twins versus singleton. But it is, as Ellie acknowledged, a prospective comparison of outcome between 1 twin pregnancy and 2 consecutive singleton. And all the obstetrical data that has been claiming that twins have higher risks do not come from such comparisons. They all came from the old obstetrical paradigm. And that was our main point of attack when the discussion started. And we couldn't get it into the heads of our colleagues that it was statistically wrong to compare apples with oranges. Now, Ellie told you that indeed, since we have made that criticism, there were 2 studies, and I will come back to those in a moment. There is one additional error in the assumption that twins have higher outcome risks than singleton pregnancies in association with IVF. And that additional error is the assumption that a singleton pregnancy conceived spontaneously and a singleton pregnancy conceived by IVF have the same outcome risks, and that a twin pregnancy conceived spontaneously and a twin pregnancy conceived by IVF have the same outcome risks. They do not. And indeed, they have inverse relationships. And there is considerable data on this in the literature. Oops, this is too early. There's considerable data in the literature that shows pretty conclusively that singleton pregnancies from IVF have much higher risks than singleton pregnancies that are spontaneously conceived, while with twin pregnancies, the opposite is true. And when you think about it, it makes sense. Because if it's a normal singleton pregnancy, whether she sees the doctor at 6 weeks or at 20 weeks makes not much difference. But with twin pregnancies, it does. And the twin pregnancies are obviously in IVF, diagnosed much earlier, followed earlier, treated earlier, etc. So even there is a bias which is adversely directed at the IVF outcomes and adversely affects the consideration of risk for twins. Now, Eli mentioned the paper by Sasanova, and this is the paper by Sasanova. And these Swedish colleagues indeed did this study, the first published study, where they compared in a national, large Swedish database outcomes for twins versus 2 consecutive singletons. And as Eli absolutely correctly cited, their conclusion from that study were that neonatal and maternal outcomes were dramatically, I repeat the word dramatically, worse in the twin patient group. Now I want to show you what means dramatically worse. Oops. Dramatically worse means that perinatal mortality was not different. APGAR scores under 7 were not different. Mortality obviously was not different. Congenital anomalies were not different. Now, what was different? There was an increased risk of sepsis. There were respiratory complications that were higher in the twins. In other words, and there was increased jaundice. And those are obviously all signs of prematurity, because we all know that obviously the risk of prematurity is much higher with twins. But I want you to also look at some of the maternal risks. There was obviously a higher risk of cesarean section with twins, premature rupture of membranes. Placenta previa, interestingly, was less frequently with twin pregnancy, more frequently with 2 consecutive singletons. There was a slight increase in preeclampsia risk, and there were no differences in either gestational diabetes and maternal mortality. What all of this means is that when you really looked into details of the study, there was indeed a mild increase in prematurity and what one would expect from prematurity. But I would certainly not call this dramatic differences, especially since what the paper also reported is that there was, and Eli also mentioned that there was no significant increase in neonatal intensive care time between the 2 groups. And I would again reemphasize, if APGAR scores under 7 are the same, how much of a difference can there really be? This brings me to our last study, where we looked at the second point, which is the difference in outcomes depending on how a pregnancy was conceived, and where I told you that there are very, very significant differences between spontaneously conceived and IVF conceived pregnancy. And this was first reported over 10 years now, 11 years ago, by Elmhurst from the Netherlands. And he showed in a review of the literature that there was roughly 40% overestimation of negative outcome risks in twin pregnancies conceived after IVF. In other words, that the twin pregnancy conceived by IVF had 40% lower perinatal outcome risks than a spontaneously conceived twin pregnancy. And this is an 11-year-old study, so what we did is we looked at the literature for the last 10 years since Helmerer's studies and repeated basically the study he had done, and what we found is exactly what he reported already 10 years ago. So not only is the basic concept that twin pregnancies at worst have marginal increased risk confirmed, but if you add those 40% lower risk, you have really no more risk difference, and probably even a risk advantage, assuming we could really make twins. And if we really could make twins, which we obviously in IVF cannot do, we can just increase or decrease chances for twins. If we could theoretically make twins, then I think combined this data would support the notion that you could actually reduce risk by having patients deliver twins rather than have 2 consecutive singleton pregnancies, not even taking into consideration that none of us fertility specialists can guarantee a patient who had 1 baby with us that if she comes back in a year or 2 that we will be successful in giving her a second baby. Now, I think I'm running out of time, so I will skip the next few slides, especially since I stole them from Eli when he gave a similar talk at our center's grand rounds. I use this only to make the point that IVF is not the big culprit in the twin epidemic. Eli showed you that data as well. IVF contributes relatively little to the twin epidemic. The big culprit are the ovulation cycles with inseminations or with intercourse. Because every time we put the patient on a fertility drug, we convert a unifollicular into a multifollicular cycle and thereby induce multiple risk, but it is out of our control. And we already, in 2000, published this paper in the New England Journal of Medicine, where we actually argued for IVF in place of ovulation induction with intercourse or insemination cycles as a tool to control multiple birth. Because that opportunity is given only by IVF. The twin epidemic that we are witnessing is because not enough patients are in IVF. Too many patients are, in my opinion, in insemination cycles. I'll skip this. And I will conclude just at the last point that single embryo transfer is also supported by the concept of pre-implantation genetic screening, which has gained so much following in recent years under the argument that it allows the selection of a normal embryo is also false. I don't have the time to go into it. Some of you may have attended the pre-Congress workshop on the theme. There is increasing evidence that PGS is really not able to reliably determine whether an embryo is indeed euploid or unemployed. And so we don't think that this is at all a useful test. And we just completed a study in egg donor cycles where even in selective single embryo transfer, we, in national data, were able to demonstrate that patients who had PGS had actually significantly lower live birth rates than patients who did not have PGS, even with elective single embryo transfer. So the last basic hypothesis provided by proponents of elective single embryo transfer also turns out not to be correct. So the assumption that twin pregnancies carry increased risk therefore does not hold up. IVF does not, to a major degree, contribute to multiple birth, and single embryo transfer also does not help us in conjunction with PGS. And therefore, we very strongly believe that elective single embryo transfer should not be performed unless patients want a single embryo transfer, oppose the chance of a twin pregnancy, or have a medical indication that is contradictory to having twins. Okay? Thank you very much.